patient has a lot of options. Could we fit this patient with custom soft lenses? Maybe. Could we fit this patient with corneal GP? Maybe. If we look at the powers distributed within the pupil, you go from approximately 58 diopters, almost 59 diopters, down to somewhere at about 38. So there's a 20 diopter spread in power on this eye, just within an incredibly small 3 or 4 millimeter span. So a soft lens might be a real challenge for this eye. Now the question is, can a corneal GP manage this big shift in curvature across the central cornea and into the peripheral cornea? So why don't we look at this eye in terms of its elevation? And when you place a theoretical rigid lens on eye in your topographer contact lens software, you can see that this eye has an incredible elevation shift. The eye is relatively high. The eye is low. The eye is very high. The eye is incredibly low. So there's this asymmetry to the eye that exists along the vertical meridian, making this a very difficult case for corneal GP lenses. So when we look at our keratoconics as an example, when we look at our irregular corneas and we consider, can we fit this patient with a soft or a rigid or a hybrid or a piggyback? Where does scleral fit on the spectrum? And in this case, we look at these eyes and we say, well, if we were to use a custom soft lens, we know we can provide the comfort, but we may not be able to provide the vision. We know we could fit these eyes with corneal GP and we can provide the vision almost certainly, but can we provide the comfort to go along with it? So many of these patients are very, very challenging contact lens cases. And I know for those of you who have joined from the Middle East, from my experiences when I visited, the severity of some of these keratoconic patients that exist in the population are incredibly high elevations and incredibly asymmetric shapes. So I can have some appreciation of how difficult it is to fit some of those patients that are in your particular region. Now, when we use a scleral lens, the benefit is that we have the comfort of a soft lens because these lenses move very similar to a soft lens. In this case, when you look at this video, you see the lens moving very, very little. But using the rigid lens of the RGP plastic, we get that very consistent and quality vision from creating a more idealized anterior surface to create a more ideal anterior curvature to bend light. So when we place a scleral lens on eye, like the SmartLens, what we're doing is providing a new anterior surface. So regardless of the irregularity underneath that lens, that front surface of the rigid lens is going to provide a much better medium to bend light properly to the fovea, creating better quality of vision. So the SmartLens is the newest generation of scleral lens. It's from our group, it's a fourth generation of lens. We've evolved, we've learned so much about scleral lenses over the past 2 decades. And all of that knowledge has gone into the construction of this next generation lens, known as the SmartLens, and distributed across the world by Spectrum International. Now, where does the SmartLens come from? Well, the CAT Design Group is the licensing body that created the SmartLens, that distributes the SmartLens around the world through licensed distributors like Spectrum International. Now, you may recognize some of the names on this list. John Mountford, very well known for his work in orthokeratology, but in his practice, he typically sees more irregular corneas than he does ortho-K cases. However, he's generally known for his research in ortho-K. Patrick Caroline, known as maybe the most recognized lecturer, educator, researcher on the planet for all his work related to the improvement, the understanding, the methods of fitting the irregular cornea and specialty lenses in general. So there's a group of clinicians, of manufacturers, of researchers that go into designing the smart lens. Now, what makes this lens unique? And one of those things that becomes very obvious when you use an OCT is to look at the zones of the lens and how ideal the back surface has been constructed to create the vaulting through the cornea, through the peripheral cornea, through the limbus, and then, as importantly, to create a landing on the eye surface that's optimized. So one thing that makes the smart lens very unique is the use of splines or straight line surfaces on the back surface to appropriately clear the tissue, but also to be able to control the elevation when you have an irregular type shape. So the smart lens was really built for virtually any eye, whether you had a normal corneal shape, an incredibly high astigmatism, a keratoconic, a pellucid, a transplant eye, a post-refractive surgery case. The smart lens was built for any one of those eye shapes. You don't need multiple different trial sets to be able to manage these varied eye shapes. Now, one thing that you'll notice that's kind of unique about the smart lens is the use of sagittal depth to create the varied heights that we need, but associated with similar base curves. So what I'm getting at is it's very common for your smart lens to use similar base curves even in a wide range of sagittal depths. Now this is different from most scleral lenses where they need to have different base curves to have different heights. Using the spline technology, the smart lens is able to create different heights of lens using the outer zones of the lens. So base curve is not used as a tool to create a higher or lower depth. Now, why is this important to you? And it's important because if you diagnostically fit a 4400 SAG lens, but you want to custom order a 4200 or a 4600 lens, then you know you're dealing with the same base curve. You're dealing with the same lacrimal lens power, and more likely you will expect to have that custom lens come in and not have any of these odd over-refractions that we often see with scleral lenses. So by using the same base curve for multiple different trial lenses, it means that your custom orders can come out a little more predictive in power when you're switching between sagittal depths, when you need a higher or lower sagittal depth. Now, when you have an eye like this, an incredibly oblate eye, the smart lens can use the outer zones of the lens to create a reverse geometry shape. You don't need a specific trial lens to fit this type of eye. You only need to find the right height. Then the custom lens can be optimized to create a more oblate shape. When you're dealing with the normal cornea that has ocular surface disease, when you have an incredibly dry eye patient, but really it's a normal corneal height, it's a normal corneal symmetry, then there's a lens in the set that can fit that height of eye. When you have a keratoconic eye, where the height of the cornea goes up by at least 200 microns, maybe as much as 800 microns, there's a depth in the set that can fit that eye. And then lastly, when you have some of our most challenging, the transplant eyes with their incredibly high depth, their incredibly high asymmetry at times, there's a depth of lens in the set that's likely to fit that eye. So the SmartLens is a vaulting scleral lens. It's designed to clear through all the corneal tissue, regardless of the symmetry or asymmetry of the eye. We want to clear through the corneal tissue, the peripheral corneal tissue, the limbus, the initial part of the conjunctiva, and then finally land way out on the sclera, on the conjunctiva. So it's a relatively simple concept where we only need to be worried about vaulting corneal and limbal tissue, and then we concern ourselves with the landing of the lens far out on the conjunctiva. Now the SmartLens trial set comes in 3 different diameters, and this is to accommodate the wide range of cases that you might fit. You'll notice in the 15 millimeter diameter, there are 2 diagnostic lenses. And the reason for that is it's rare for us to need an incredibly small scleral lens. In cases where the eye is very small in diameter, we can use a smaller diameter scleral lens. In cases where the eye is incredibly deep set and it's difficult to apply that lens to the patient, then you have a small lens option that gives you the ability to place the lens on eye in a less problematic manner. However, when you're dealing with more median depth eyes, when you're dealing with more median diameter eyes, then you may want to consider going up to the larger 15.5 diameter lens. And then for the vast majority of your advanced cases and your large eyes, then you have the 16.5 diameter. So you'll notice that the trial lenses are concentrated between the 15.5 diameter and the 16.5. These are the diameters of lenses that you're likely to use the most. And the ones that you'll be least likely to use have the least number of lenses in the diagnostic set. Now, the SmartLens was based on numerous studies that were done at Pacific University, mostly by our team there, but also taking into account studies that were done around the world. And the construction of this lens is based on a deep appreciation of the shape of the cornea, the shape of the peripheral cornea, the shape of the limbus, and maybe most importantly, what's happening far out on the sclera. So when we look at corneal scleral topography or OCT study of the eye shape beyond the cornea, it's well understood that the closer you land a scleral lens to the borders of the visible iris, the less asymmetric the eye is. In other words, the closer we are to the limbus, the more likely we are to need a symmetric landing scleral lens. So your small 15.0 diameter is a symmetric alignment zone or symmetric landing. The 15.5 moves the point of bearing farther out on the sclera, and therefore you're moving into more asymmetric or toric shape. And therefore, the 15.5 diameter SmartLens has 125 microns of toricity in the landing. And that's to better fit the more asymmetric shape of the conjunctiva. Now, when we use the 16.5 diameter lens for our more advanced cases and our larger corneas, then we're dealing with a lens that's landing much farther out on the scleral surface where it's landing on eye shape that becomes far more asymmetric, we are more likely to need a toric landing. So your 15.0 lenses are symmetric in landing. Your 15.5 lenses are slightly toric, 125 microns of toricity in the landing. Your 16.5 diameter lenses have 150 microns of toricity in the landing. Now, this toricity becomes valuable for a number of reasons. First, you can see how well it may align to the toricity of the scleral surface. If we take this diagnostic lens and rotate it 90 degrees off axis, let's see what happens with that lens to surface relationship. Notice the diagnostic lens wants to return back to that same point that we began with. In other words, the toricity of the lens is matching the toricity of the conjunctival surface it's landing on. And this is important because it creates a more appropriate landing on the sclera, and it also helps when you need a front toric lens, which we'll discuss shortly. But the important thing to know is that your SmartLens diameters that are larger, the 15.5 and the 16.5, use a standard toric landing in the alignment zone. Now, this has been found by numerous studies in Europe and in the US or North America that when you use toric scleral lenses on our larger diameter lenses, you improve the fit, you improve the physiologic response. You can improve comfort slightly, and you can improve the wearing time during the day. So by using a toric landing lens, which the SmartLens does, we may be creating a more optimal way to land that lens down on the eye surface. Now, there's a percentage of cases that we fit with scleral lenses that require front torics. And this is odd because in corneal GP fitting in the irregular cornea, we don't fit a high percentage of patients that require some kind of front toric lens. Now, why is that with scleral lenses that so many of our cases, approximately 15%, require a additional astigmatism added to the front of the lens? We have lenticular or residual cyl induced by the lens. So don't be surprised that a good percentage of maybe 10 to 15% of your scleral patients may require a correction of the residual astigmatism. And this is where the SmartLens is truly smart, because by using a back toricity that's appropriately aligning to the sclera, that's staying on axis, that lens can now have the front toric optics added to the lens, and you as the practitioner will be confident that that lens will stay on axis. So this creates more efficiency in our scleral lens practices because we're going to put a toric landing diagnostic lens on our patient. If they require spherical optics through the lens, then we don't need to do any kind of advanced calculation. However, when we do have residual astigmatism, we don't have to go to a completely different diagnostic lens. We can simply call up Spectrum International and say, I put on the toric landing 16.5 and I had a residual astigmatism or residual prescription of -2, -150 axis, whatever it was. And the Spectrum group can then order that appropriate front toric lens for your patient. Now, how do you choose the initial smart lens? Is it a complicated process? Do we need K readings? Do we need topography? Do we need OCT? Is there some fancy way that we need to consider to select the initial lens? And the truth is, it is incredibly simple. The only thing you need to be armed with is an understanding of the condition. Am I dealing with a normal eye? That's an eye that's going to have a low depth. Are we dealing with a post-refractive surgery patient? That's a patient that may need an even lower depth. Are we dealing with an early cone or a pellucid marginal degeneration? That's going to be a higher depth. Are we dealing with a keratoconic eye? That's likely to be a much higher depth. Are we dealing with a keratoglobus or a very advanced cone? Then of course we're going to need a very high depth lens. So the condition is much more important than the K readings or the topography. You don't have to worry about numbers pulling out of your topographer to come up with that initial lens. It's as simple as saying, am I dealing with a normal cornea with ocular surface disease? If I'm choosing the small diameter lens or the medium diameter lens, I'm going to choose a 3400 micron sagittal depth. If I have a bigger cornea, then I'm going to choose the 16.5, in which case, if it's a normal cornea, I choose the 4000 micron depth. If we're dealing with a keratoconic eye, you know that's a higher depth eye, so you're going to go up in sagittal depth to a 3800 if you're using the smaller diameters, or you're going to go up to a 4400 if you're using the larger diameter. Now, the toughest patients to choose a initial diagnostic lens are the transplants, because as you know, they come in so many different heights. They come in symmetric, they come in tilted, they come in asymmetric. So for the transplants, it's always safest to go with the largest depth and a higher depth to begin with. But as you can tell, this is a very simple process. Am I dealing with normal cornea? I start with this lens. Am I dealing with keratoconic eyes? I'm going up by approximately 400 microns. Am I dealing with a transplant? I'm going up again by approximately 400 microns. So it's a very simple lens selection process. Now, what are the fitting considerations with the SmartLens? And really, we have three principal areas that we want to concern ourselves with. And it's quite simple. Does the lens clear through the central corneal tissue? Does the lens clear through the peripheral corneal and limbal tissue? Does the lens have an appropriate landing on the sclera? So as you're evaluating these lenses, you may consider starting from the center to the periphery. Did I choose a lens with an appropriate height, or do I need to exchange this diagnostic for a different trial lens? Now, the SmartLens has 4 different zones. Zone 1 through 4, and each one has a specific function that relates to its underlying anatomy. So let's talk about each one of these zones. First, zone 1 is the zone that should vault through the central cornea, should clear all the corneal tissue. If we have a keratoconic with diseased central corneal tissue, we don't want to agitate it by landing the lens on that surface. So creating a healthy vault is the goal of the zone 1 or the central vault zone. In that zone, you can alter the sagittal depth in your trial set. You can go up or down by 200 micron increments, or you can also alter the base curve. So if this is my standard trial lens and I want a small 100 micron adjustment, I can steepen the base curve by 2 diopters, and that will increase the sagittal depth 100 microns. So in other words, for every 1 diopter of base curve change, equates to a sagittal change of 50 microns. So if I have too much sagittal depth in my trial lens and I want to take away 100 microns, I could flatten the base curve by 2 diopters, 2 times 50 microns. I'm taking away 100 microns of sagittal depth. So the base curve can be used to alter the central apical clearance of the lens. But I have to be honest, I rarely change the base curve in the SmartLens. I use the second zone of the lens to do most of my modifications. And this is how the second zone works. It is the peripheral corneal zone adjustment in the lens. In other words, the central optic zone of the lens is modified in height by changing the peripheral corneal zone, or zone 2. That's lifting or dropping the apex of the lens. We want zone 2 to vault through the corneal tissue to create a healthy relationship between the back surface of the lens and the eye surface. We want no corneal bearing through zone 2 or zone 1. But the way you can use this zone to your advantage when you want to change sagittal depth is by increasing or decreasing the zone 2 value. So for instance, if I want to decrease the apical clearance, I can make zone 2 minus 4 steps. 4 times 25 equals 100 microns of sagittal change. So put another way, when you adjust the peripheral corneal zone 1 step, you change the sagittal depth of the lens 25 microns. So each step, a 25 micron adjustment. If I make the peripheral corneal zone, zone 2, minus 4 steps, I'm taking away 100 microns of apical clearance. Conversely, if I were to increase the peripheral corneal zone 4 steps, I'm now adding 100 microns of vault to the central vault of the lens. So the peripheral corneal zone can be used, as you can see in these images, by creating a more reverse geometry or oblate surface for your post-refractive surgery patients, or it can create a more prolate surface for your more bulging eyes, like your keratoconics. So I use the peripheral corneal zone, I use zone 2 to lift or drop the center when I need adjustments of approximately 25 microns to maybe 200 microns. Now the third zone in the lens is used to lift or drop the vault that occurs at the limbus. So what you do in this zone is you would use it to lift when that lens is hitting the peripheral cornea and limbal junction, or when it's too close to the initial conjunctiva that's very close to the limbus. So the zone 3 limbal lift zone is used very frequently when you have peripheral corneal or limbal bearing. And you can see that here, where the lens may be very close to the limbus. By increasing the limbal vault, I'm moving that lens away from the limbal surface. I'm creating more vault between the corneal tissue or limbal tissue and the back surface of the lens. So by adjusting the lens 5 steps, again 5 times 25, each step is a 25 micron adjustment. I'm raising the sagittal depth of the lens approximately 125 microns. It's very rare to need less limbal vault. I can count the number of times I've ordered a SmartLens with a negative limbal lift zone adjustment. But what that does is it decreases the vault at the limbus. So this can be useful when you have conjunctival prolapse. That can be a way that we can decrease the amount of vault through the limbus and peripheral cornea. Now, the final zone in the lens, and one of the ones that's most important in scleral lens fitting, is our landing. Do we have the appropriate lens to surface relationship in zone 4, where the lens touches down on the conjunctival surface? And here we're looking for a lens that is not fitting in a tight manner where it's cutting off the vessel supply of these large and small capillaries right at the lens edge. So this is where the angle of the zone 4 or the scleral landing zone may be too aggressive or too steep for the underlying surface. The lens is pointing in to the conjunctiva. Whereas what we would like to see is our smart lens matching the angle of the underlying surface to the angle of the lens. So the edge points along the surface, not into the surface, not above the surface. The typical adjustment to a smart lens is to require increased edge lift. As the lens sinks into the conjunctiva, if its angle is inappropriate, you may need to increase the angle. So by doing that, you'll order scleral landing zone -1, -2, or -3. And why minus? To increase the edge lift. And the reason is that in the smart lens, any adjustment to any of the zones will alter the sagittal depth by 25 microns. If you're making a one-step adjustment that's decreasing sagittal depth, that would be a minus adjustment. And when you increase the edge lift of any contact lens, you are decreasing the sagittal depth. If you were to tighten up the lens edge, that would be a plus adjustment. You're increasing sagittal depth. So for the landing zone of the lens, if you had a mild tightness, if just one side were marginally tight, you might order scleral landing zone -1. If you had opposing points of conjunctival blanching, if the lens appeared tight on opposing side, you're going to order scleral landing zone -2. If you have greater than 180 degrees of this blanching or a tight edge relationship, you're going to order scleral landing zone -3. So of course you understand if I order a scleral landing zone -1, I'm decreasing sagittal depth 25 microns. If I order scleral landing zone -2, I'm decreasing the apical clearance 50 microns. If I order scleral landing zone -3, I'm decreasing the apical clearance 75 microns. So with the smart lens, it uses sag as a way to adjust each one of the zones. And this makes it incredibly easy for us to understand because we're always dealing in height. We're always dealing in micron adjustments. As an example, the sagittal depth of the lens, each diagnostic lens, is separated by big jumps of 200 microns to make a significant alteration to the fit. The second zone in the lens, the peripheral corneal zone, is adjusted by one-step adjustments equaling a 25 micron change in sagittal depth. Zone 3, the limbal lift zone, one step equals 25 microns. Zone 4, the scleral landing zone, one step equals 25 microns. So you know that whenever you adjust any of the outer 3 zones in the lens, if you're making a plus adjustment of one step, you're adding 25 microns of sagittal depth to the center. If you make a negative adjustment, -1 step, you're taking away 25 microns of height. So when you fit the smart lens, your first observation is make sure you have the right sagittal depth of lens. Did I place a lens on eye that's hitting the corneal tissue? Do I need to go up in sagittal depth by 200 microns, by 400 microns? How much will clear the central corneal tissue? We want a lens to go on eye that appears like it's vaulting all of the central and peripheral corneal tissue. Now, we may put a lens on eye that has the appropriate apical clearance, but it has peripheral corneal or limbal bearing. When that's greater than 180 degrees, you need to call up the team at Spectrum International and ask them to increase the limbal lift zone, raise zone 3 of the lens to get that lens off the limbus, off the peripheral cornea. Now, if you have less than 180 degrees of thinning, this is a case where you may want to monitor the patient over time. So as an example, if we see less than 180 degrees of this thinning, it's usually related to decentration of the lens. So this is a case where we may want to have the patient wear the lens for as long as possible, 4 hours, 8 hours, then take the lens off and stain the cornea. See if there's any real bearing, because this may be false touch. This may be thinning of the fluid, but not true bearing. When you have 180 degrees or more of thinning, that's almost certainly corneal bearing, and that's going to disrupt the epithelial surface that needs to be adjusted. Now, lastly, going to the outer zone of the lens, of course, if we're cutting off the vessel supply, we need to call up the team at Spectrum International, ask them to alter the scleral landing zone of the lens. A mild adjustment would be scleral landing zone -1. A more moderate adjustment, scleral landing zone -2, or a more significant adjustment, scleral landing zone or zone 3 will order a -step adjustment. Now, the smart lens is also available as an asymmetric. So you have the ability to land a symmetric smart lens surface. You can fit a toric landing, or you can lift just one section of the lens. You can create an asymmetric. You can make the elevation of each one of these 4 quadrants completely different, making it utterly asymmetric. It's more common to use one of the axes to lift or drop the surface, especially when you have a pinguecula. This may be the most common reason to use an asymmetric smart lens. You can also fit a multifocal smart lens where the center has the most minus the distance, the near toward the outside. The lens can be built so that the powers within the pupil can be provided specific for each patient. In other words, if you have a large pupil and a high power shift, you can order the lens so it creates the appropriate distribution of power for that specific pupil size. If we have a more typical smaller pupil where we need to distribute far more power within a smaller area, that can be ordered from the Spectrum team. So why is the smart lens smart? What makes it truly smart? Why is it appropriately named in this manner? And to close off this session, well, let's just discuss some of those features that may make this lens a really good choice for your practice. And one of the first considerations is this lens was built for the most normal of eye shapes or for the most irregular of eye shapes. The smart lens at our school is used more often than any other scleral lens. And the reason for that is it's easy to use and it fits all the irregular eye shapes that we see come through the practice. The radial keratotomy, the post-refractive surgeries, the normal corneas with ocular surface disease, the merging keratoconics, the bulging keratoconics, the tilted grafts, and the very bulging grafts. So this lens has an incredible range of eyes that it can fit. We have multiple diameters that the lens is available in to be able to fit the very small fissure, the deep set eye, the incredibly small cornea. We have a median diameter that's useful for our less asymmetric eyes, our eyes that are slightly bigger, but they aren't so bulging or asymmetric in shape. Then we've got the 16.5 for the eyes that are large, for the more asymmetric or advanced conditions. So you've got a number of diameters in your diagnostic set for a fair range of patients. Now, in the smallest diameter lens, there are these unique markers that are used to determine when you need a larger diameter lens. So when we're using the smallest 15.0 diameter, we want to be sure when do we lift the vault of the lens through the limbus, or when will that be inadequate? When do we actually just need a bigger scleral lens? And these Zone 3 limbal lift markers are meant to show you when the diameter needs to be increased. So for instance, at least of this marker should be on the conjunctiva. This is the width of the zone 3 of the lens. And if 100% of the limbal lift zone marker is within the borders of the visible iris, that's telling you you have too small a lens. You need to go larger. Now, looking at the other diameters, you'll note that you have the vast majority of lenses concentrated between the 15.5 and the 16.5, where you're most likely to use a larger diameter lens because we're fitting conditions that are more asymmetric or more advanced in scleral lens fitting. We have a small number of the smallest diameter lens for our incredibly small eyes. And then using the diameters in, the base curves in the SmartLens, you'll note that it's typical that you're putting a much flatter base curve of lens on eye. Now, why is this important to you? And this is important because your patients aren't going to need powers of -16 diopters when they're a keratoconic steep cornea. You're going to be using typically flatter base curves of lenses. So that reduces the lens power, and it also reduces the thickness of the lens, creating, of course, better oxygen permeability. So this is a really smart feature of the SmartLens, that we're using much flatter base curves for each of our sagittal depths of lens. Now, the construction of the lens was based on volumes of research that we've done at Pacific University, and taking into account research that's been done in other corners of the planet, and that's all gone in to the building of this lens to make it as forgiving as possible. So you should very often find that the initial diagnostic lens will often fit without requiring a large degree of modifications. And that's because we have a very good understanding from these many studies of the normal depth of the keratoconic eye, of the angle of most eyes, of the appropriate landing that's required for the vast majority of cases. So you should find the SmartLens is a very forgiving construction. And using the spline technology, it creates this incredibly elegant relationship of lens to surface vaulting, and the ability to alter zone 3 to increase the limbal vault, to alter zone 2, the peripheral corneal zone, to lift or drop the sagittal depth of the center. Then lastly, the SmartLens uses an incredible edge that creates a very forgiving landing. Now, when you look at these different lens designs, only one of these is the SmartLens. And you'll notice the huge difference in construction of many different lenses that are available in the market. And you'll notice that one of these looks particularly ideal in the way it touches down on the eye surface. And here is the SmartLens. Notice the vault through the corneal tissue, the vault through the limbus, the vault through the initial conjunctiva, and then this beautiful relationship of landing on the eye surface. Compare this to the other 6 lenses that you see there. You'll notice that every scleral lens has its own signature. And I would argue that the signature of the SmartLens is really idealized for landing on the conjunctival surface. And that's seen here in this image where you have the vaulting through the corneal and limbal tissue, but then you have this perfect relationship of lens touching down, distributing its force. But then at the edge, notice that half of the apex of the edge is above the eye surface, half of the apex of the edge is landing in the surface as that lens sinks into the conjunctiva. And this is the ideal lens to conjunctival relationship that reduces the blanching, that reduces the red eye, that creates a comfortable fit with the eye, that creates a good physiologic response. So the SmartLens creates a lot of efficiency in practice. And part of that efficiency is created by using the toric landing. When you land a lens with a toric back surface on a toric conjunctiva, if it's rotationally stable, then you're able to add your residual astigmatism when you need the front toric. So while the scleral lens may sit at this axis, the cylinder can be at a completely different axis. So you understand by placing your toric landing 15.5 or 16.5 on eye, if it's rotationally stable, you know for those 10 to 15% of patients that require front torics that you can add the residual cylinder to the front surface, knowing that it's going to stay on axis. This creates great efficiency in practice because I don't have to pull another diagnostic lens out of the set. I don't have to order a different diagnostic lens from the distributor to place on eye to determine if I can create rotational stability. I know that from my 15.5 and 16.5 diagnostic lenses. So do amazing things for your patients. If you're new to scleral lenses, then the SmartLens is one of those scleral lenses that's going to be able to help you with your highly irregular eyes, your transplants, your ocular surface disease patients. It's built to fit an incredibly broad range of patients. Now, if you're a current scleral user, and you're looking for better efficiencies in practice, if you're looking for a lens that may improve that initial comfort, if you're looking for a lens that may make it easier for you to achieve higher first fit success, consider the SmartLens. This is a lens that was constructed to create both efficiencies in practice, but create a high first fit success and long-term success for your patients. So this next generation of lens is available from Spectrum International today. The SmartLens diagnostic set comes with those 3 diameters and those 16 sagittal depths available for your wide range of eyes. So for more information about this lens, talk to Felipe Arroyave, the president of Spectrum International. Reach out to their team and they'll be able to provide you more information about both the fitting, but also how you can get the initial diagnostic lens. So we'll end the session just by thanking you for logging in to this webinar. And we hope that it's had value to you, and we'd be happy to take any questions that you have at this point. Felipe, do we have any questions that have been asked
Yes.
up until this point?
So people have been asking a lot of questions and I've been answering them as you were speaking. Thank you so much for this wonderful presentation. We're getting more and more questions. So Dr. Elias, hello. So concerning the multifocal scleral lenses, is better to give you the exact size of the pupil to fit a better design? Or we just need to tell you what the pupil is and if it's normal or larger size? What do you think about that?
Yeah, it's an excellent question. Of course, if we have a ad that's distributed over 3 millimeters, but we have an incredibly small myotic pupil that is only 2 millimeters, we need to know the size of that pupil to appropriately distribute the power. So if it's possible to measure pupil size with your corneal topographer as an example, that may be the best way to help us build that initial multifocal lens. Now, if you don't have the ability to measure the pupil size, then of course we can begin with the first custom order having a median, a large, a small diameter aperture of that ad. So in a worst case scenario, small, medium, and large is fine. And ideally, if you can measure the pupil size in normal illumination, that would be the best way to start. But of course, as you know, with scleral lenses, we fit these on very difficult eye shapes, very difficult conditions. It's not uncommon that we need modifications to power, to the landing. And in a multifocal, it certainly wouldn't be uncommon that we need to alter the size or increase or decrease the ad to create better effect for near distance. So my point is we can always adjust the lens as we move forward to optimize the outcome.
Thank you, Randy. And we do have Dr. Nasser Al-Shami. He knows you very well. He's spoken to you before. He's located in Oman, and he has heard multiple conferences from you, Randy. He had a question. Dr. Nasser, can you please?
Yes, Felipe, how are you? Nice to hear your voice.
Nice to hear your voice, brother.
Thank you for your invitation for this nice presentation from Dr. Randy. Dr. Randy, this is the fourth generation of the scleral lenses, as you have explained. But why we still should worry, about changing the parameters of the zones, and that is going to change like 25 microns still from the central zone.
Yeah, an excellent question. If this lens were the fourth generation of our research and it can't fit first fit success every time in the diagnostic lens, why is that? And it's a very simple answer. We know from the scleral studies, we know from the corneal studies as well, that the corneal sagittal depth can range by at least 800 microns. In some cases, it can be as broad as 1800 microns. So we need in the sagittal depth, we need an incredible range of sagittal depths for just the cornea. But what's a bit invisible to us, it's very difficult to do OCT measurements of the scleral angle that are efficient. In other words, when we use OCT to appreciate the angle of the limbal shape, the initial conjunctiva, and as we go farther out in the sclera, it's very challenging to understand if we're dealing with low or high scleral angle. So what I mean by that is we can take two patients. One can be an incredibly low 30-degree scleral angle. One can be an incredibly high 50-degree scleral angle. So if we're using diagnostic lenses that were built for the absolutely normal 38-degree scleral angle, then the diagnostic set is probably going to work absolutely perfect. But if you have a patient that has an incredibly low scleral angle, then the edge will fit tight and you'll need to adjust in the custom order to have a alteration to the landing zone. If you have an incredibly high scleral angle, then you're likely going to need adjustments to the third zone in the lens, the limbal lift zone. So that's the reason that we need diagnostic lenses, because we're going to place it on eyes where we may understand the corneal condition, we may understand from our topographer the corneal depth, but we will not be able to understand the range of scleral angle. And I've seen transplant eyes that were 57 degrees in angle, knowing that normal is 38 degrees. So that patient needs a severe adjustment to the construction of the lens. We can be dealing with, I've seen as low as 28-degree scleral angle. So that's a patient that needs around a 10-step adjustment to the landing of the lens. Now, thankfully, these patients are not very common, but it will happen. So I hope that makes sense, Dr. Nasser, as a reason why you're going to need to make big adjustments at times. And I've certainly seen in my Middle East visits that we have these very advanced keratoconic patients where the lens needs to bulge forward an incredible amount, and that bulging may not be enough to alter just the central sag of the lens. We may need the peripheral corneal zone to increase in vault. We may need zone 2 and zone 3 to bulge forward to be able to clear that very irregular eye shape. Does that answer your question?
Yes, 100% positive, Randy. Only that my question was if we are adjusting, the peripheral zone or the landing zone, why that change happened, in the central zone? Why we cannot keep it just the same as the vault that I need in the central zone?
Oh, I'm terribly sorry. My apologies. So you're saying if you alter the edge lift and you want to keep the apical clearance the same, is that possible? Is that correct?
True.
Okay. I'm so sorry. My sincere apologies.
No worries.
Because you understand that each adjustment to each zone, one step is 25 microns, then you know you can compensate in the other zones. So for instance, let's say that we need to increase the edge lift 2 steps. So scleral landing zone, zone 4 minus 2 would be 2 times 25. I'm taking away 25 microns of sagittal depth. I can compensate for that loss in sagittal depth by making zone 2 plus 2 steps. So minus 2 steps in the edge lift will take away the 50, but plus 2 steps in zone 2 will add back that depth. So you can compensate with any of the zones of the lens, or you can just tell Spectrum International that I've fit the 4200 sag lens. I want to increase the edge lift 3 steps, but I want to keep the depth the same. If you tell Spectrum that adjustment, their consultants can automatically make that change.
Dr. Nasser,
thank you so much.
If you're comparing that to the current design that you're currently fitting, the current design that you're currently fitting does the same thing. If you alter the scleral landing zone, you're going to have an alteration in the central zone with every single design, Dr. Nasser, because think about it geometrically. think about it about the actual design of the lens. If you're actually decreasing the landing zone, you're going to be decreasing the chord of that sagittal height as well. So that is not only with the SmartLens, that is with every single design of scleral lenses in the market. For
No,
example,
my question, sorry to disrupt you, Felipe. My question, just to raise the point that for the audience also to notice that, as Randy explained, if you change one quadrant, okay, or sorry, one segment or one fitting zone, you have to compensate in the other zones as well. You know, you have to take that in consideration, or otherwise you have to inform the lab to do it for you. So that's only the point.
But it's only in the scleral landing zone.
And the peripheral zone as well, I think.
Yeah, I don't want my scleral lens, if I'm dealing with a distributor and I have a scleral lens that's making auto adjustments to all of the zones, then that may take control out of my hands that I don't want. As an example, if I adjust the edge lift and there's some auto adjustment to another zone, that may land the lens where I don't want it, or that might create a change somewhere else that I don't want. So the reason why the SmartLens allows the independent control of each section and there isn't an auto adjustment, it's to make sure if I wanted to increase the edge lift and I wanted to decrease the sag 50 microns at the same time, I just adjust the edge lift. But if I, as Dr. Nasser pointed out, if I wanted to increase the edge lift, but I didn't want to decrease the sag, then I need an adjustment for that. So the system was created so that the user can make an adjustment when they want compensation, or they can make an adjustment if they don't want compensation.
Sure. Thank you, Randy. Thank you, Felipe.
Thank you, Dr. Nasser. So we have more questions, Randy. So Dr. Lama is asking, hello, concerning the scleral lens multifocal design that you provide, is that dominant eye requirement?
Excellent question. It is built to create the multifocality required within each pupil, but you don't generally fit a different optic for dominant or non-dominant. Now, having said that, it may be necessary to make the distance eye have a larger optic zone. It may be necessary to have the non-dominant eye with a smaller central a smaller optic zone. So you may adjust the lens after that initial custom lens. I want to be very clear with everyone out there regarding multifocal scleral lenses, and the SmartLens is no different. It is critically important that we have good centration of the lens because, of course, as many of you know, scleral lenses typically position temporal and inferior, but our pupil and our visual axis is nasal and superior. So if our scleral lenses are going to be positioning down and out and our line of sight is up and in, or nasal superior, then these lenses may struggle to provide patients with good quality of near and distance vision. So when I'm looking at multifocal fitting, I'm always looking first at, can I expect the optics of this lens to line up with the patient's line of sight? Because if it's a typical slightly inferior temporal position, I'm presuming the multifocal may not work. So that might be the most important consideration in fitting scleral multifocals. Now, the good news is that very soon, expected in the next quarter, Spectrum is going to be able to provide you with a displaced smart lens, a displaced optics smart lens. So if the lens optics and the line of sight are separated by 1.5 millimeters, you can move the lens in the direction, you can move the multifocality in the direction of the line of sight.
Perfect, Randy. Thank you so much. We do have another question. Why can't you just adjust the scleral landing zone in positive steps and in the landing zone, in the steepen the landing zone, as when you want to steepen the landing zone? Why does it have to be negative?
Yeah, so when we place at least a smart lens on eye, it is not very typical for this lens to have edge lift. It's more likely that the lens will either sink into the conjunctiva when there's too much edge lift, rather than having a lens tip off the surface. But in those rare cases, and I've only had maybe one where the lens needed to be tightened, that's when you're going to order a scleral landing zone, a zone 4 plus adjustment. Now, the reason why the zone 4 is labeled as increased edge lift, is a minus adjustment, is because we want you to think that every time I adjust a zone in the smart lens and it's a positive adjustment, I'm always increasing the vault of the lens. Every adjustment to zone 2, 3, or 4, that's a minus adjustment, you are always decreasing the sagittal depth of the lens. So the reason why an increased edge lift is a minus adjustment in zone 4, it's because in any contact lens in the world, this is any lens, not specific to SmartLens. If you increase the edge lift only of the lens, you decrease sagittal depth. That's a universal outcome of any modification to a contact lens edge. So that's why the smart lens uses a negative adjustment for increased edge lift, because you are decreasing sagittal depth. And as we discussed, we always want to know what we're doing to the vault of the lens. If I change zone 2, if I change zone 3, if I change zone 4, what am I doing to the height through the cornea? I never want to have a lens touch the central cornea. I never want the lens to touch the peripheral cornea or limbus. So I need to be aware of any adjustments that are going to affect that vaulting through the center. I'm not so concerned about excessive sagittal depth. I don't see too many patients with any kind of oxygen permeability issues. So too much vault isn't very concerning to me, but too little definitely is. Having a lens landing down on the corneal tissue, I'm very concerned about.
Perfect. Dr. Marina, I don't know how to pronounce her last name. I'm sorry if I'm mispronouncing your last name, Dr. Marina. Seliga. She says, thank you, Randy. It is a pleasure to listen to you again.
Oh, thank you.
Dr. Nesar, a great friend of mine, does peroxide affect the lens material?
As long as it's a approved GP lens, we haven't seen peroxide as an issue at all. In fact, solution systems like ClearCare have been a great option for our scleral patients, because they take the lens out of the case with they really don't need an incredible amount of rinsing of the lens. You know, basically that neutralized fluid becomes like saline. So we've been really happy with systems like ClearCare that are providing, leaving the lens in that neutralized fluid. Of course, rigid lens fluid is always good. It was designed to make a hydrophobic rigid lens more hydrophilic, but of course, to rinse off the conditioning fluid can take a lot of saline. It can increase the costs to the patient. So one of the advantages of using a peroxide system is that it's so easy to rinse. It really, you know, the argument is, does it even need a rinse? So yeah, with the systems that we have available, at least in North America, now my apologies, I'm not so familiar with all the fluids that you have accessible to you in the Middle East. We've been really happy with the peroxide systems.
Yes, just remember that once these lenses come with HydraPEG, HydraPEG can be affected by peroxide. So just be careful and please ask questions before you use peroxide with HydraPEG. And please just refer all your questions to our consultants.
Excellent point, Felipe.
Thanks, Randy. Does the lens has plasma treatment or HydraPEG? Yes, Virginia, we were just talking about it. The lenses do come with plasma treatment right now. And Randy, the lenses will contain HydraPEG in the next few months, right?
Yes, that can be ordered upon request.
Okay. What is the lens material made from? It is Contamac material. We have two materials. We have the Optimum Extreme and we have the Optimum Extra. But usually the lenses are going to come with Optimum Extra. If you need a different material, please let us know. If I want a quadrant specific at C4, for example, at zone 4, nasal is tight, temporarily is flat. Will this affect the sagittal height?
Good question. I would presume if the lens is landing with a degree of pressure at 12 and 6 o'clock, and we need to lift 3 and 9 o'clock in the at nasal and temporal sides, that by lifting one and decreasing the other, the sagittal depth shouldn't change too much, presuming the lens is landing with some weight across the vertical meridian. But I'm certain that there'll be some change to the sagittal depth. I would just expect it to be subtle. I have to be honest, I haven't needed to use a lot of asymmetric lenses, but in the times that I haven't found that it's altered the depth enough that it created a problem. Now I'm fitting with a lot of central vault. I'm usually going for 300 to 400 microns of vault on application, 200 to 300 microns after settling. So that gives me a lot of room for that lens to come down and sink and settle over time. And one of the problems that I think we all face is that we may evaluate a patient at 9 in the morning, at noon. Maybe if it's a late appointment, we evaluate them at 5 o'clock or 7 o'clock. But that patient may wear the lens till midnight. So how much settling will happen between the time we see the patient and the very end of the day? So I'm always happy with more vault. And I think when adjusting for these asymmetrics, that really gives me lots of room for there to be error.
Perfect, Randy. I'm so sorry. I was answering a question. People are asking us if the webinar was going to be in Spanish. No, this webinar is not in Spanish. This webinar is in English only because it's for the Middle East. We have a great question. Dr. Aldik. Does the patient feel the lens while it rotates because of the lens toric design? Could the toric design affect the comfort? Because I think it is the first toric design I saw, at least. Doctor, yes, we do have a great toric design. This design is not like other scleral lenses that you have seen in the market that they keep rotating and they rotate constantly. You are going to be able to put front toricity in these lenses and you're not going to have the problems that you are experiencing with other lenses. This is the smartest lens in the market right now. And yes, you can put toricity in front of the lens, but let me ask Randy if does affect the comfort of the patient, or do you think the patient can feel the rotation?
Let me find that video again, because it may be worth looking at this video. Felipe, are you able to see my screen?
Yes, I'm able.
Okay. I am not sure how to answer that question exactly, because when I put my finger on the lens and I rotate the lens off axis, I'm probably altering the pressure of that landing a fair amount. And some patients will say that they can feel that. They can feel when I rotate it. But when you take your finger away, I don't think patients can feel that rotation. I would say generally I haven't heard any comments, probably at least 80 to 90% of the time. I don't think patients are aware that that lens is rotating on their eye. Now there may be some that do, but remember also that the toricity is incredibly subtle. In this lens, we're talking about the 16.5 having only 150 microns of difference between the axis with the scribe, so that's the flat meridian here, and the axis without the scribe, that's the steep meridian, somewhere around 12 and 6 o'clock. The major difference in comfort that I've found with a symmetric versus a toric is if I were to fit a patient with a scleral lens and they are brand new patient to contact lenses or a brand new patient to scleral, they will usually say that the comfort is an 8 out of 10 on a scale. So in other words, a symmetric scleral lens is usually 8, maybe 8.5. Now, if we put one eye in a symmetric landing and one eye in a toric landing scleral lens, like the SmartLens, then usually the patient will choose the toric as immediately being more comfortable. When we ask about the comfort scale of the symmetric versus the toric, patients may say the symmetric is 8, 8.5, and the toric is 8.5, 9. So it's incredibly small, the difference in comfort, but it's enough that it's noticeable to a wearer. So I think you will find by fitting more toric landing scleral lenses like the SmartLens, that initial comfort may be just a tiny amount better than it would in a symmetric. And if you've got that right alignment like this lens does, where you have the perfect match or all must be near perfect match of toricity of landing to toricity of sclera, that lens will be incredibly stable. You know, look between blinks. If there's any rotation of that lens, it's incredibly small. So these lenses are very, very stable on eye because in the research by Greg Denier, they found that something like 6 to 10%, I don't remember the exact number, but it was under 10% of patients have symmetric scleral shape. So that means that the 90% or higher has asymmetric or toric scleral shape, and therefore we really should be fitting toric scleral lenses for most eyes. I hope that helps.
That helped a lot. So we have two questions. Where is the base curve in the zone? Zone 1, 2, or 3, or 4?
The base curve would be zone 1. And that central zone can be adjusted in base curve, but I rarely adjust the zone 1 base curve. The rest of the lens is using either splines or using a opposite radius base curve. So in other words, there is no other curve to the construction of the lens other than the central zone. The zone 1 is the only section. The rest of the lens is using splines.
Awesome. Randy, last two questions. In the case of transplants, what is the ideal central clearance?
Oh, wow, what a great question. As many of you know, we have some of these older grafts that were transplanted at a time when we weren't doing a great job of preserving the graft after the harvesting. So the endothelial cell count goes down incredibly low in these eyes. And so for these patients, they're just so sensitive to the apical clearance. And we may have to be incredibly close, measured in maybe 100 microns above the transplant. It may be we have to try to come lower than that. But as you know, with transplants, they're often tilted, they're asymmetric, and to be 50 microns in one section means you're 600 microns in another section. So these are very, very challenging cases. we try in the transplants to be in the neighborhood of 100 to 200 if we can, and that's presuming that we are not putting the host donor transition point at risk of bearing at any point in the day. So I think that our goal with any of our transplants is to be monitoring the edema very closely, and to make sure that our fit isn't increasing edema to the eye, because they're just such challenging cases. And we have many transplant eyes that we really had to take out of scleral lenses because that eye was very close to expiring to begin with, and almost anything we put them into is just decreasing the oxygen. So I apologize, I'm not doing a very good job of answering this question, but I think if you're thinking that 200 microns will clear through most of the cornea and there isn't any point where you're going to be in touch, then you're relatively safe on most transplant eyes. If you see some signs of edema, you can reduce the sagittal depth of the SmartLens. You can control it in steps of, we talked about 25, but you can actually go in steps even lower than that if you needed to. You can make the SmartLens thinner. So there are things we can do besides reducing the apical clearance to try to increase the oxygen permeability of the lens.
I think you answered that perfectly. I was going to say between 150 to 200, but I think that was the best answer ever. Thank you.
Pleasure.
So we do have the last question, and this question is from Dr. Caesar. What do you do when and this is a really good question. What do you do when the lens rotates permanently? And when you keep doing the spin test and it keeps rotating, or when the lens stops in an area that you have tried to spin it and it has stopped?
So the lens is not rotationally stable? Is that the question?
So for example, if they perform the rotation test and the lens keeps rotating, what do you do then? And what happens when you do the rotation test, just like you show, and the lens stops at a certain axis? What do you proceed with those two cases?
So if we believe the lens is not rotationally stable, then I would take the lens off if it has any fluorescein underneath it. I would take the lens off, I'd rinse the eye, I'd rinse the lens, and I would put the lens back on without any fluorescein at all in the bowl. So we want the lens to go in without fluorescein anywhere. Then you're going to set the patient up behind the slit lamp, and you're going to, let's call it, paint the front of the lens with the fluorescein strip. So I have the patient behind the slit lamp. I'm observing the lens on eye with cobalt light, and I'm going to just reach around the slit lamp, touch the anterior surface of the lens with the strip, and immediately watch for where the fluorescein may come in behind the lens. Now this is important because if we go back to our video, if we can see where the fluorescein is coming in relationship to the markers, then you know if you need more or less toricity. So this isn't the best example, but here we have our lens with fluorescein behind the lens. We have the slit lamp set up for white light. But let's presume we've placed this lens on eye without fluorescein and we have our cobalt light. Then we're going to paint the front surface of the lens and watch very quickly, does the fluorescein come in? I'm going to try to stop this video. If the fluorescein comes in at 12 and 6 o'clock, if you notice that it's leaking in underneath the alignment zone at 12 and 6, and this is the steep meridian, you know you need more toricity. The markers are the flat meridian of the eye. The opposing unmarked axis is the steep meridian. So if fluid is coming in here, that means that the lens doesn't have enough toricity, and that may be why it's rotating on eye. That may be why you can move it off axis and it doesn't want to come back to any similar point. Now, conversely, if we stain the front surface of the lens and we notice that the fluorescein is coming in underneath the marker, so near to where the markers are, that means that we have too much toricity. The lens is landing along the steep axis, too heavy, and lifting along the flat axis. So we need to decrease sagittal depth. So that's a very important tool that you will, or method that you can use when you're trying to determine, do I have the appropriate landing? If my lens is not rotationally stable, use the fluorescein test. If the patient is uncomfortable in the lens, use the fluorescein test. If the lens is moving excessively, use the fluorescein test. This tells you whether you have an appropriate landing on the eye surface. Felipe, was that the answer? Did I answer the question?
That was completely clear, but also just to make sure that the doctor understood, the markings can also guide you, doctor. So for example, when you're fitting a patient and you tell us that the markings are 3 and 9, or whatever the markings rotate to, please let us know so that we can design the lens, and we can design a front toric lens based on the rotation that that lens had on the patient's eye.
That is such an important point, Felipe, that this research has shown that the corneal astigmatism and the scleral astigmatism do not typically match up. In our studies at Pacific University, we found that only 20% of the time did the corneal and scleral toricity match. So in other words, your flat meridian, where these markers are, can be almost any axis 360 degrees around. The markers may be anywhere depending on where the flattest meridian of the sclera is. So your the axis of the markers and the axis of the cylinder are often going to be different points. So the first thing you want to tell Spectrum when you need a front toric is, what axis do these markers sit at? It's not, do we have 10 degrees of counterclockwise or 30 degrees of clockwise rotation? That doesn't matter. What matters is these markers are sitting at axis 175. We want to tell that to Spectrum. Then you would denote where is the astigmatism. What sphere, cylinder, and axis do you have as an overfraction? So it's not, again, this is very important point. It is not important that these markers be at 0,180. It's important that wherever they are, they're rotationally stable. And in this case, this patient has a width of rule scleral shape, but it could be almost any axis for the astigmatism that may be coming through. In my case, the markers sit at 12 and 6 o'clock. I have a spherical cornea, but apparently I have an against the rule scleral shape because the flat meridian markers on my eye position at 12 and 6 o'clock. So you really don't know where those markers are going to be, but as Felipe said, it's critically important when you need a front toric that you communicate the exact axis those markers sit rotationally stable at.
That was awesome, Randy. Thank you so much for piggybacking on the answer that I gave the doctor. Okay, thank you. So, Mustafa Abdu, could it be possible to explain more about the fluorescein patterns with SmartLens? What do you mean, Dr. Mustafa? The fluorescein patterns when you're fitting a toric lens, or the fluorescein patterns when you're actually fitting just a normal spherical lens? If it's a normal spherical lens, it's just the fluorescein pattern that you're looking on a scleral lens, where you don't touch the central zone, you don't touch the limbal zone, and you land softly on the conjunctiva and the sclera. Yeah, Dr. Mustafa, it's just like any regular scleral lens. You need to have between 150 to 300 microns of clearance centrally, and then you cannot touch the central zone, which is the central part. You cannot touch the limbal, and you have to land softly in the conjunctiva. Did we answer your question? Okay, apparently we did. Randy, thank you so much for your help. Thank you for being here with us. For any participants that still have questions, you can email us. Please use the email address from where you received the invitation, and you can email us directly. But if you need to email me directly, I'm going to type in my email address on the chat. This meeting was recorded, and it will be sent to you by the end of the week. So every person that registered is going to have a link to download the video. Randy, thank you so much for being here with us.
Thank you, everybody, for being on the session. And Spectrum International, Felipe, thank you for setting this up. This was a lot of fun.
Thank you, Randy. And you had people from all over the Middle East: Jordan, Kuwait, Iraq. You had people from Oman. You had people from Bahrain. You had people from all over the Middle East. So thank you for helping us reach this technology to everyone around the world.
Oh, that's so great to hear. Wonderful.
Thank you, Randy. Talk to you later.
Thank you very much.
Bye-bye.
Bye.